Yes, Sarita, let's start.
Yeah.
Good evening, sir. Sunawala, sir.
Hello, good
Madhuriya.
evening.
Madhuriya.
The video is not coming on. I think.
No, it is coming.
Yeah, we can see you, sir. We can see you.
Yeah, but
No, now
sound-
it is gone.
Yes, we can hear you also.
also
Now it
Good
is
good,
all
evening,
seen.
sir. Good evening.
good evening to all of you.
Good evening, sir.
Good evening.
That's it. Sarita, you are starting. Sarita का network.
Lakshmi should.
Yeah. So, very good evening, one and all. And as ICOG chair, I'm.
Should start. Are we going live?
Arey yaar, you got muted.
You got like
So I started, Sarita. So as
Go ahead.
Yeah, I have already started. So as
We're
ICOG.
not yet live, I think.
No, sir, we are live.
Recording.
Yeah, it is recording. Where you want us to be live? We don't have any FB page.
Fine.
Yeah. So Sarita, are you with me? She gets muted off and on. Sarita?
I think my network is going and
Yes,
coming.
sir.
Go ahead. Go ahead. Yeah.
Yeah. So very good evening, one and all. And I am very happy to be with you all once again with our Guru Mantra web series. And this time we have Dr. Narendra Malhotra, teacher's teacher. And I'm so happy to welcome him on behalf of ICOG for his Guru Mantra on FGR. Sir, you are most welcome for this ICOG Guru Mantra web series. And
Thank you. Thank you.
also would like to welcome our two great experts, Dr. Madhuri Patel and Dr. Charmila. They will be formally introduced by our co-convener, Dr. Sheila Mane. And I also would like to welcome our convener, Sarita, co-convener, Sheila Mane, along with all the delegates who have logged in from nearby countries just to meet and hear our Guru, Dr. Narendra Malhotra, sir. So I welcome all dear delegates from India, from all the other countries for this ICOG Guru Mantra web series. And so let's have happy learning. I hand over to Dr. Sheila Mane to formally introduce our experts and our Guru. Dr. Sheila?
I think Dr. Lakshmi, I will introduce the experts and Dr. Sheila is going to
Yeah.
introduce the speaker.
Yeah. Nilima, share karo screen, experts ka.
Dr. Sheila, would you like to start?
You introduce the experts, no? I'll
Okay.
introduce.
Okay. That's, yeah, I'll go ahead. So thank you very much, Dr. Lakshmi. And it gives me great pleasure to welcome our experts. This is our 6th episode of Guru Mantra. And I think each time our attendance is going up, but this time it looks like it's a record attendance. May I welcome Dr. Madhuri Patel. Dr. Madhuri Patel is our Secretary General of FOGSI, the first Lady Secretary General of FOGSI. She's been the Joint Secretary of FOGSI in 2009. She's a committed academician and a teacher, and she's been a professor at the Grant Medical College in Mumbai and is currently the Honorary Clinical Associate at Wadia Maternity Hospital, Parel. She has delivered many guest lectures and she has many publications and books to her credit. And the most important one is her book on cancer, which has received many awards. Our next expert is Dr. Charmila. Dr. Charmila from Trichy is the is the Vice President-elect of FOGSI 2024. She's been the chairperson of the Clinical Research Committee. She's a very active ICOG Governing Council member, and she has held many prestigious positions, as you can see, as National Coordinator of UNICEF FOGSI PA, National Coordinator of the MEDA FOGSI PG program, coordinator of the ISAR Gurukul 2022. And really, when you look at Charmila, you wonder, are there 24 hours in a day or are there more than 24 hours? So welcome our experts, and over to Dr. Lamane to introduce our Guru for today.
Dr. Sheila, please unmute yourself.
Yeah. It's my
Dr.
proud
Sheila,
privilege. Can you hear me?
Yes, now we can hear you.
can you change the slide?
No. I can see his CV.
Yeah, please go ahead.
Okay.
Yeah.
Most of us know Dr. Narendra Malhotra, but it is my proud privilege now introduce him. As Dr. Lakshmi said, that he's the teacher of teachers now, and he's a professor of Dubrovnik International University of Croatia. Again, FOGSI representative to FIGO. He was President FOGSI in 2008. Then Dean of ICMU 2008, Director Ian Donald School of Ultrasound, National for FOGSI GOI, that is MacArthur Foundation of EOC course, Honorary Professor at DMI MS. Chairman Publication Committee of EOFOG, practicing obstetrician at Agra and special interest in high-risk ultrasound, laparoscopy, infertility, ART, and genetic, and I think I will have to add aesthetics also now. I think we are hearing a lot from him. Member and fellow of many Indian and international organizations, and FOGSI Imaging Science Chair he was in 96 to 2000. He has had many awards to his credit, and he had also ethical award, Man of the Year award, Best Citizen of India awards. Over 50 guest lectures given in India and abroad, and presented 10 orations. He has organized many workshops, training programs, conferences, and we all are aware of the beautiful and excellent, AICOGs.
Madam, you're muted.
Step
Yeah.
by step books, revising it for the Jeffcott's textbook of Gynaecology, and Donald Obstetrics and Gynae Manual in 2012, and very active sportsman, Rotarian and social worker. So over to you, Dr. Narendra. And I think now next time, whenever we meet, I think we will have to really look into this and see to it that all of us also get you as well as we are also active on the ground for the sports. So I welcome you for your talk on FGR.
Thank you very much. It's indeed a pleasure to be here at the ICOG Guru Mantra, and I am really thankful to all of you for choosing me as the Guru, though I am still a student and still a learner of many, many more things. This Guru Mantra is a fantastic series which you all have started, and I think it's being enjoyed a lot by everyone, and very nicely enjoyed. So what I'm going to today talk on is take you through the journey of fetal growth assessment, the concepts of fetal growth retardation, and how do we plot growth charts, and how do we go ahead and diagnose and try to manage FGR. So the key questions which arise are: what are the risk factors for abnormal fetal growth pattern? What measurements should we be taken to assess the fetal growth correctly? What are the typical ultrasound features of poor fetal growth? And what are the typical ultrasound features of macrosomic fetal growth? And how is fetal growth assessed in twin pregnancies? This is a question and challenge faced by all the obstetricians and the radiologists and the fetal medicine specialists. So my learning objective for my talk today is, what I plan is that by the end of this lecture, you should be able to use ultrasound to distinguish between normal and abnormal growth patterns in both singleton and twin pregnancy. That is what we're going to try to show you. Remember, for all obstetricians and fetal medicine specialists, it is fetus first. And way back when antenatal care first started, the fetus was assessed only in the last trimester. But as technology improved, the pyramid of antenatal care was inverted. And today we are assessing the full fetus by all the modalities in the first trimester. And it is now possible to predict a lot of congenital anomalies, chromosomal anomalies, and fetal growth restriction and maternal PIH and preeclampsia in the first trimester. So whatever modality you have with you, use it to the best to give the best for fetus. And remember, our aim is fetus first. And this is what the fetus will look like. So let's see what is normal growth. Now, normal growth depends on two parameters. And those parameters are genetic potential of the baby and the substrate supply or the food supply to this baby. There may be a small for date baby, or there may be a growth retarded baby, the small ones. The genetic potential comes from both the parents and is mediated through growth factors, which are insulin-like growth factors, which the fetus will grow inside the abdomen, inside in the 9 months. And the substrate supply comes through the placenta. What a woman eats, breathes, and that goes through the placenta to this fetus and is used for the growth of this fetus. So if there is a problem in both of them, there is going to be a problem with this baby. So the placenta and the uterine arteries of the uterus are going to supply the substrate to this baby, to this growing fetus, so that it achieves the full growth potential, which it is inherited from its parents, the genes. And of course, a lot of the substrate depends on maternal nutrition. So if it is a starving mother, if it is mother on high altitudes, if the mother not eating properly, having medical disorders, other things, it is not going to work, or the substrate is not going to do. So how do we first clinically evaluate? We do serial management, serial measurements. And serial measurements, symphyso fundal height, abdominal girth. Fundal height, as we all know, as we were taught, increases by 1 centimeter per week, 14 to 32 weeks. So that's how, in our times, we had only that as the thing. And a lag of 2 weeks showed that it was moderate fetal growth restriction. A lag of 4 weeks indicated that it was severe fetal growth restriction. But this method only has a very low sensitivity and only 44% sensitivity for detecting fetal growth retardation if you're going to do it clinically by doing only the symphyso fundal height measurements. So when ultrasound came, it became accurate on how to assess the fetal gestation. And the first thing is the crown rump length. Now remember, all these are objective, they are operator driven. And if you just put the cursor wrongly, you'll get a wrong crown rump length. And also there is an error attached to all the growth parameters. And we have to understand this error because we have to fit this error when we are going to accurately do the growth. So the accuracy of crown rump length between 7 to 10 weeks is plus minus 3 days. And the bigger the fetus grows, the accuracy decreases. And 10 to 14 weeks, the crown rump length has a disparity of plus minus 5 days. So that is a margin of error. And after 14 weeks, we do not measure the crown rump length. So the margin of error in measurement of crown rump length is plus minus 1.2 millimeters. That is the 2 standard deviation. And roughly when you are doing it in your OPD yourself and not reporting or just looking at it, the gestational age is equal to crown rump length plus 6.5. And that is how we make out. And see how it is measured outside from the crown to the rump. The fetus is semi-flexed with a part of liquor in between the chin and the thorax. And you see that the spine is semi-flexed, not extended, not overflexed. And it is coming in the whole of the screen. So you're magnifying the whole of the screen to get the whole fetus or the embryo in the screen. Then we have the other parameters in the second trimester. I'll come to you about the growth charts. Let's do the what all parameters. So we have biparietal diameter, that is measuring from both the parietal bones. These are our parietal bones above our ears. And we have a head circumference, and then we have the abdominal circumference and the femur length. So the biparietal diameter is measured at this level above the ears. The abdomen is measured at this level about the entry or just above the entry of the umbilical vein. And the femur length is measured straight, and you don't measure the condyles or the epiphysis. So that is how we do the measurement of these hard bony parts. So let us see one by one. The biparietal diameter. You have to get the correct plane. And the correct plane is the arrow sign or the threshold sign, as we call it. The black inside here is the thalamus. The cerebellum is here. The arrow is pointing posteriorly. And you're not seeing the, you should not be seeing the ventricles. And the cavum, septum, pellucidum are the two bright lines. So here we measure from outer to inner. And on the same scale, we measure the circumference. It could be ellipsoid or trace method. The head circumference and BPD are well measured in the second trimester. The transverse cerebellar diameter is measured from here to here, and it gives you in weeks of how it is up to about second trimester. So in the second, not in the third trimester. The next is the abdominal circumference. You get the abdomen, get entry of the umbilical cord, but the umbilical vein is seen like a J shape. The stomach bubble is seen. The cross section, 3 laminae of the vertebra. No kidneys to be seen on both sides and no straight. So the umbilical vein, we know, comes and it goes up. So we have to get the correct plane. And here you will measure manually, or you will measure by your ellipsoid method, or some machines now automatically measure. Now we're getting on machines which will tell you automatically that you're not in the right plane or not. So talking machines have come. So for beginners, it would be a good idea that if you have someone to guide you, if you have not learned your ultrasound. The femur length as straight as possible in the thigh, and you go down and see the bladder and then rotate the probe, and you'll get the femurs, and try to measure both the femurs. And then with all these, we have the measurement ratios, which the machine will calculate or your software will calculate, which may or may not be helpful. So the biparietal diameter, as I told you, is measured at the level of the thalami, the cavum, septum, pellucida, the sylvian fissure, and it is known as the arrow sign or the threshold sign. And if you're not getting the probe correct, in the correct plane, see, if you get the whole FOGS, then it is not in the bio. We know that the FOGS comes from up and divides up to the thalamus. So after thalamus, it's a midbrain, it's a single. Only the cerebellar part is divided. So if you get the full FOGS, that means you are above the thalamus. So the FOGS cerebri has to be interrupted at the thalami level. So only this part. That is the level. The biparietal calipers are outer to inner. The accuracy is about 7 to 10 days up to about late second trimester. And in this third trimester, the inaccuracy is 2 to 3 weeks. So if you got 4 ultrasounds done, the crown rump length will give you 1 EDD. The second trimester by BPD probably changes the EDD, and the third trimester is 3 weeks difference. So please don't get scared. The EDD never changes. The EDD will remain by the first scan, and do not use machine generated data. So that is how we will go about doing the growth by prep. Now the limitations is if the head is flattened or head is too rounded, brachiocephaly or dolichocephaly, then you use cephalic index, and cephalic index is biparietal diameter divided by occipitofrontal diameter into 100, and then we can use this. So, and also when it is breech position, when you press by the probe, the head moves. When it is vertex, then when you press by the probe, the head stabilizes with the pelvic bones. So, you in breech also you might get different. So the BPD errors are interobserver, wrong section, and not at the right BPD level. So, and or it can change with the various clinical index where you do the cephalic index. So you do cephalic index in breech and leaking, and when the twins, and the average for the cephalic index is taken as 78, if the range is 74 to 83. A grossly decreased cephalic index means the head is dolichocephalic, and an increased cephalic index indicates or diagnoses that it is brachycephalic. For head circumference, the anatomy is the same, and then we measure the head circumference. And either you do biparietal or occipital and apply the formula, or you directly trace it, which the machine will do it directly to you. So towards the end of the pregnancy, this might be a better parameter to use than to use the biparietal diameter. And it is not affected in early growth retarded. The markers are the same: FOGSI cerebri, FOGSI, the cavum septum pellucidum, the thalami, and the arrows. And the calipers are from outside to inner, and for tracing, you take the wide calipers at the outside. So it is, then we come to the abdominal circumference. Now, abdominal circumference is circumference of the abdomen. You get the right level, as I told you. The J-shaped umbilical vein, the stomach, no kidneys, cross section of the spine, and no entry of the, you don't see the umbilical vein full, because umbilical vein is running obliquely from the entry of the umbilicus to the liver. So you only see this part, the straight part. And this is probably the best parameter for detection of fetal growth retardation. Abdominal circumference below 5 percentile for gestation age is because the liver is reduced, because the glycogen stores are depleted in the liver because of substrate depletion from the placenta or from the maternal nutrition. So it has the highest sensitivity and the greatest negative predictive value. But you will enhance the sensitivity if you're doing serial measurement 14 days apart and plotting them on a chart. And that is exactly what we want all of you to do. Use the charts. So this is how you get the abdominal circumference at that level: umbilical vein, aorta, spine, and stomach bubble, and the liver parenchyma. So this is how it looks: J-shaped umbilical vein, fetal vertebra, stomach bubble. Then we come to the femur length. Femur length, you image both the ossified and do not measure the trochanters or the condyles. And the angle should be about 40. If you're not getting it, just tilt your probe or rotate your probe to get the full length, as we're showing you in this depiction here. So exclude the triangular spur of the artifacts at the distal femoral epiphysis also. So femur length as straight as possible, and you measure it. Then you have the various ratios: the HC-AC ratio, 16 to 40 weeks. The HC-AC ratio is more than 2 standard deviation, is predictive of fetal growth retardation, because the head circumference is growing, abdomen is shrinking, the head's brain sparing effect. And if it increases, it is fetal growth retardation. Femoral length versus AC, gestational age dependent index, its normal value is 22 in the second half pregnancy, but these are all academic values. And the abnormal values of FL versus over AC or HC over AC will indicate asymmetrical growth or growth differentiation. Then we need to know the weight of the baby. Since growth is a dynamic process, the quantification requires serial measurement. And we use the Shepherd formula for growth. The smallest mean difference not applicable if the weight is less than 200 grams. And this is the formula which is used. Now this formula is fed into all machines, and the machine will automatically calculate the weight. So you have Hadlock's formula, you have Campbell's formula, you have Shepherd's formula, and you have Mer's formula. All of them are approximately same, but they are all for Western babies. So we still use all these formulas in our Indian machines, but here I would like our Indian data to be fed into the machine. So the international standards for fetal growth is based on serial measurements of HC, BPD, AC, and femur. And this was known as the Intergrowth 21st Project Study, which was published in Lancet. Now, then WHO has provided us growth charts. So this study says that plot all the things in the growth chart. Wherever the patient comes with BPD, it'll. So these are very simple now. And if you go to Google, who has all the answers, and type growth charts there, you will get a sample growth chart. So BPD, AC, whatever. You print it out and you start plotting it on a graph and keep it with the patient's antenatal file if you want to do it manually. Otherwise, the machine automatically prints a growth chart by it. But there is still no international agreement because the parameters for West and the parameters for India are different. Now, here is the parameters from India, and I acknowledge the original work done by S. Suresh from Chennai and Paras Advanced Center from Ahmedabad, Dr. Prashant Acharya. And they have put in the charts which are now recognized world over on all the parameters: BPD, HC, AC, female length, and fetal weight. And finally, one of these days, Indian machines sold in India will probably have these charts. So this is Indian biometry chart, which was published in 2018, and we should be using these charts in our machine. So Indian by BPD chart, Indian head circumference chart, Indian according to our Indian abdominal circumference chart, and the centile values, which will indicate whether it is IU's growth retarded or not, and the centiles. So similarly, all these charts and their clinical relevance have been made by our Indians. And see, you have the center, and if it is below, then you call it the centiles. Or if it is above, you call it the above centile. So macrosomia and small for date or growth retarded babies will be easily diagnosable. And we'll show you how also. So these charts should be now used, including the estimated fetal weight charts also. So estimated fetal birth weight chart is one of the good charts, which is here. And this has all been recognized by the ICOG, the International Society of Ultrasound and OBGYN, and the INSWOG, the Indian Society of Ultrasound and OBGYN. So these have been published and these have been well acknowledged the world over. And we congratulate the mammoth work done by Dr. Prashant Acharya and of course. Now see how it happens. The term 40 weeks birth weight for fetus 3.3 kilos 51 grams for a normal primary gravida weighing 52 kgs and an average height of 152. That is in our Indian population. While the European population has at 40 weeks, the weight would be 34 and their average weight is 64 and their average height is also in. So that difference has to be kept in mind. And also the Indian babies mature earlier. So maybe our babies are full term at about 39 weeks, 1 week before the European. That is why we don't usually wait till 41 weeks to call them post date. That also has to be now worked at. So every fetus, as I told you, has a potential to grow because of its genetic potential and because of its substrate potential. So based on this, when the growth is getting poorer, we now classify growth retardation as early onset or late onset. The early onset both could be symmetrical or asymmetrical. When you have an early insult, it is more likely to lead to symmetrical growth retardation rather than asymmetrical. That means all parameters below the 5th centile or lower margin. When it is late onset, it could be symmetrical or it could be going normal and then dipping down. So we have set a few guidelines for fetal growth. And let us see and follow all these guidelines. So fetal growth guideline number 1 is that assign a gestation age by accurate measure of crown rump length at or below 10 weeks. That means 7 to 10 weeks. Understand the variability, 3 days is normal, and then do a serial scan for growth. So gestation is assigned by one reading, and growth is assigned by serial growth, serial reading. That need to be understood. So get the crown rump length measured correctly and see the same fetus if in different positions is measuring differently. And accurate technique is very, very important, which I showed you in the first slide. So then when you get the crown rump length, you compare it with the LMP, if the patient is sure of the LMP. If she is not sure, crown rump length EDD is given to her. If she's sure of the LMP or says my LMP is likely this, and if the difference is less than 1 week in the growth, then you assign the EDD according to the LMP. While if the difference is more than 1 week, then you reassign the EDD according to the crown rump length. So this is your guideline number 1. Crown rump length, assign or reassign the EDD based on the normal variability. That is why I'm saying more than 1 week, more than 7 days. Now here, this patient, the EDD was this, it was measuring like this, but by ultrasound, the discrepancy was more than 1 week. So the EDD was reassigned from 10th November to 23rd November. And from 12 weeks, 6 days to 11 weeks. So this is now, this date will not change with subsequent scans, even though the machine will give you different dates. But your EDD can be 1 year, not many. Now for second trimester dating, head circumference is the best. You will change the date from the LMP if the gestation USG difference is more than 8%. So first trimester was 7 days, here it's 8%, or what we call it the rule of 8. Again, correct measurement, and then again, because some patients may come to you in second trimester. So you have no first trimester scan. So you want to give the EDD or the growth, because now you want to chart the growth charts. So do a growth dating scan in the second trimester by HC, and the error is 8%. Now, in view of the inaccuracy of the BPD, should not be routinely used for giving a dating scan. So we use the HC. Now let us see what happens now. The patient comes to you 14 to 20 weeks. She gives a LMP, and then you do a composite biometry gestation. That means average of the BPD, female length, HC, AC. Compare it with the LMP. If it is less than 10 days, because the error is 10 here, then you let the LMP age continue. But if the difference is more than 10 days, then you correct the EDD and rechange her EDD, and that will mark now the growth. What about 21 to 26 weeks? That was 14 to 20. The error is 14 days. So now your reassignment will occur if the difference is less than 14 or more than 15. What about over 26? Over 26 weeks, we usually avoid giving a dating scan because the patient is presenting late and she has no scan reports. But still some parameters can be used. But remember, it is the inaccuracy on prediction has a high variability. So based on all this, your guideline number 2 is after fixing a gestational age and an EDD, which may be due to LMP or a reassigned EDD due to ultrasound, do not change the date in subsequent scans. Do not use the machine-generated data blindly after this. And that has to. Now, after 26 weeks, we apply the rule of 8%. So now you see, determining of the menstrual age, LMP by LMP, 155 days. By ultrasound, it is coming 142 days. So the actual difference is 13. Now, expected margin of error is 8%, we said. So 8% means 142 days into 8 divided by 100 or multiplied by 0.08, as we say. And it is 11.36 days, not 13. So actual difference, more than expected difference, change the date. Here we will change the date by 2 days. EDD. Understood? It's very, very simple. 8% by ultrasound by LMP. You calculate the days, minus those, you get the actual difference, and by ultrasound into 0.08 or into 8 divided by 100, the difference, expected margin of error. So if the difference is more in expected margin of error, change the dates. If it is 11, less 10 in this, then. So your diagnosis of growth retardation will depend on your abdominal circumference less than 10 centile and expected fetal weight less than 10 centile. So here is the growth chart, which gives you a visual. So we get the chart with 2 red lines and 1 green line. And when you first scanned at 20 weeks or first scan usually at 13 weeks, you'll put here, and then the second scan here. And when you do after 3 weeks, if the scan is following the blue line or the green line, it is good. Growth is normal. If the growth starts at the lower centile and dips further, it is asymmetrical growth retardation. So diagnosis of growth retardation, abdominal circumference versus expected fetal weight. Abdominal circumference is the best parameter. It has a sensitivity of 98% because you're using single parameter. When you use expected fetal weight, which is calculated by BPD, femur, and AC, your sensitivity falls to 85%. Still good enough. So again, we got the growth chart from Hadlock, Warsaw for fetal weight. And then, of course, as I told you, we have from Prashant Acharya, our own growth charts. Now, whenever there is a growth discrepancy, we have to look at the Likert. And some people said that use only Likert for predicting growth retardation, taking the AFI as 5 after 26 weeks. But if you take AFI 5, the sensitivity is 24%. Specificity is very good, but that's not to be used. We use it along with it for fetal well-being. So here is your growth chart at 20 weeks, at 26 weeks, at 32 weeks. So growing well and growing on the higher side on the third scan. So if it is going to the higher side, this may likely go into macrosomia. So test the blood glucose here, test the genetic potential, look at the parents. If they're huge, big build parents, then this might be just normal. So the genetic. So the first scan which we do is the dating scan. And the 10 subsequent scans will tell you the growth. So there are 2 different things, dating and growth. So your guideline number 4 is the growth curve must be plotted for all fetuses to give a visual effect. And this visual effect is very, very essential. And you will get the visual. See, blue line normal, black line severely growth retarded baby. Again, blue lines, all lines below the centile. So symmetrical growth retardation, asymmetrical growth retardation. Just by looking at the chart, you'll know this baby is growth retarded. So charts are very, and when you correct, even with the corrected dates. So head circumference, abdominal circumference, female head chart, fetal weight chart, all charts to be plotted by the machine. So growth restricted baby will not be parallel to the normal curve. They will be like this. See? So this blue potential baby caught up, the other one remained certain. Now, based on the baby could be, or the fetus could be small for gestation or could be large for gestation or average. So low potential of growth retardation will say that this baby is small. And we have to differentiate between small babies and growth restricted babies. And large is, of course, high growth potential, parents are big, or there is macrosome. Again, the charts are going to be telling you. So when we look at small babies, 20% of them will be intrinsically small. Parents are small. 40% would be low growth potential. So 60% of small measured babies will be actually normal and not growth retarded. We are worried only about growth retarded, growth restricted baby. So 40% of the babies which are small by ultrasound will be actually growth restricted. So small for gestation baby is defined as constitutionally small baby, which could range from 25 to 60% in all pregnancies. And while growth retarded babies are abnormal babies. So how do we differentiate it? By using the correct date, by using the correct measurements, by using all the tools for biometry, and by doing clinical examination. And then adding color Doppler to it. So if color Doppler is normal in fetal vessels and uterine artery, the diagnosis of growth restriction or retardation is doubtful. So small for gestation age babies will have a normal color Doppler, and we'll just try to tell you what is normal. So we use the umbilical Doppler and we use the cerebral Doppler, because when the growth restriction occurs, the baby will shunt all the blood to the brain and the cerebral vessels will dilate, which had 30% blood or 0.7 RI restriction on a low pulsatility. So, and the umbilical, which was already dilated with 50% blood, will constrict. That is growth retardation. And in small for gestation age babies, this will be normal. So that is how we differentiate between SGA and FGR. So now we come to the ultrasound detection of FGR. So serial weight measurement, as I told you, serial abdominal circumference, routine ultrasound after 24 weeks in low risk is not required. You can go ahead and straight away do a third trimester scan for your Liker and for any other thing. The risk of growth retardation, you should know maternal risk, external factors, placental risk, and fetal risk. And all these etiologies should be kept in mind in screening for all pregnancies. So in fact, the ultrasound report should have, a fetal medicine report should have this: no maternal risk factor, no external factor, smoking, infection, psychosocial, no fetal factor, no genetic anomaly, scan was normal, genetic screening was normal, congenital anomaly was normal, and placenta is not showing any filamentous attachment or uterine anomaly. So the fetal causes of growth retardation are diagnosed by karyotype, and by anomaly scan. The maternal causes are done by maternal screening, and the placental causes are diagnosed by doing a Doppler. So the patterns of growth, fetal growth, if it is symmetric, 14% anomalies, asymmetric 4, AGA 3. Survivors, symmetric 86%, 95% will survive if everything is going on normal. And preterm baby is also about 6 to 14%. So here are two symmetrically growth retarded babies, lower centile weight. And then with the other obstetric outcomes will also be affected if there is a growth retardation: birth weight, preeclampsia, preterm baby, fetal death, and oligohydramnios. Also, the biochemical markers will show abnormalities in fetal growth retardation due to chromosomal anomalies. So doing a PAPE, an HCG double marker in the first trimester, or actually now doing 5 markers in the first trimester: PAPE, beta HCG, inhibin, alpha fetoprotein, and SFLT/PIGF or PLGF. SFLT is not yet freely available. 5 markers, penta marker, along with mean arterial pressure, along with uterine artery Doppler, will predict which fetus at 13 weeks is going to have growth retardation, which mother is going to have preeclampsia. So we have tests now to do all that. Now, if it is a small baby and growth retarded, then it is likely to have, the fetal causes will be trisomies, monosomies, then some uniparental disomies, and placental mosaicism. Or they may have gross structural anomaly with a chromosomally normal fetus, or fetal infections, or some rare genetic syndromes. So growth delay might be the dominant feature of chromosomal anomalies. So if there is a first trimester growth delay or growth small, start looking for these. Like triploides, 18, 13, Turners, Klein and trisomy 21 or Downs. So these are the odds ratio where they'll have, with the crown drum length shortened, then it's likely that these may be chromosomal anomalies. So do a good pentamarker or a NIPS or a amniocentesis. So symmetrical growth retardation, if it is there, then you do a good anatomic survey. You can do infection survey, karyotype, and look for associated anomalies, and they may be constitutionally small babies. So how do we monitor placental dysfunction? We monitor by growth, serial growth 2 to 3 weeks difference. We monitor the compensatory mechanism by Doppler. The brain will show more blood, the umbilical will show less blood, or altered cerebral placental ratios. We will monitor the hypoxia and acidemia by looking at the fetal venous Dopplers or ductus venosus, and the environment by doing a CTG and a biophysical profile. So gestational age is a single point entry, growth is a multiple point entry. And gestational age tells me how old the fetus is, growth tells me how it is growing. So based on all this, the definition is estimated fetal weight below 10 centile is FGR. Fetal abdominal circumference less than 2 centile, 2 standard deviation is SGR. Failure of fetus to reach its growth potential is FGR. And this is done by all these methods. The impact this may have is the perinatal mortality is 6 to 10 times, preterm stillbirths are more, term stillbirths are more, and intrapartum asphyxia is more. So we need to identify what are the causes of these growth retardation and take adequate measures so that, and then we have to risk or weigh and assess the fetal health, because if we need to deliver them. So the steps taken by ultrasound is you assign a fetal age, you assign a fetal size, you estimate a fetal weight, you do an amniotic fluid index, you do a color Doppler and a complete biophysical profile, or a modified Winslow's biophysical profile, because Manning score has 5 variables and they may be inaccurate. You assess all the maternal risk factors, which might be everything, environment, drugs, and all the maternal diseases, hypertension, cardiac, autoimmune, thrombophilias, renal diseases, they all, which will be, tell you that this may be asymmetrical IUGR. You assess the placental anomalies and the cord anomalies, which will tell you it is asymmetrical IUGR, and you plot them all on the graph, which will tell you whether it is symmetrical or whether it is asymmetrical. In the fetal causes, the congenital infections and chromosomal anomalies cause, and genetic syndrome cause symmetrical IUGR, like this, lower centile. So FGR ultrasound is an early dating scan. Disparity, adjust the age, assign an EDD, do not change the EDD, follow up then visually on growth charts, do a color Doppler and timely intervene. If Doppler is available, it may identify FGR versus SGA, and if Doppler is available, then growth retardation. So what is Doppler? Christian Doppler told us that when energy strikes some particles, it reflects back according to the frequency. And this he said while lying on his rooftop and seeing the stars twinkle. Stars kyun twinkle karega? They send steady light, but it is the dust particles in the atmosphere which cause the reflection and cause. Similarly, the RBCs flowing in the blood vessel are flowing at a speed, and when the sound wave hits the RBC, the reflection is seen as the Doppler wave. And this is in systole, you see the long wave. When the heart is in diastole, the muscular artery contracts again, pushes more blood, and this is diastolic blood flow. Of course, you don't have to do all this. These are very high-end machines to analyze the aortic arch and all. But when there is a substrate deficiency, the aortic chemoreceptors will pick this up first and the oxygen, and then they'll cause reflex redistribution of the cardiac output. So the vessels to the brain, vessels to the heart, and vessels to the adrenal, these three will selectively dilate and the rest will constrict. So if the kidney vessels constrict, oligohydramnios, lungs vessels constrict, RDS after delivery, gut vessels constrict, necrotizing enterocolitis after birth, body stores constrict, glycogen, fetal growth retardation. So please carry home this concept today. Normal ranges versus critical endpoints have to analyze. That does not mean if a parameter is abnormal, an emergency cesarean should be done immediately. All parameters have a gestational age related normal range. And a frequent indication of immediate delivery is when the mother's condition is deteriorating, uncontrolled blood pressure or uncontrolled sugars, or the fetal condition is deteriorating via ductus venosus or venous. So what happens when the placenta buries, the spiral arteries are torn off, the resistance becomes less, the uterine artery dilates, and you get good blood flow in the placenta and a good substrate exchange. So if there's improper implantation, then there will be problem. So where do we do Doppler? We look at the vascular bed resistance of the placenta by looking at the uterine side and at the umbilical side, both sides of the placenta. We identify the fetal adaptation by looking at the brain. And we identify fetal decompression by looking at the venous circulation, that is ductus. All these have to be done. So fetal Doppler in fetal growth will identify the etiology, tell you the hypoxia, and tell you when to deliver. So here is a normal uterine artery, non-pregnant. Peak systole, diastolic notch, peak diastole. So the resistance here, the diastolic to compared to the systolic is 30% blood flow. All our arteries will have like this. When pregnancy occurs, the diastolic blood flow increases, the notch disappears. And this is a very, very good sign because now we want the uterine artery dilated. We want all substrate to go to the fetus. So 50% of blood flow compared to the systole. By looking at the wave pattern, a lot of obstetricians say we can't understand Doppler. And you can see these waves. This is 30%, this is 50%. These are good. And this is no diastolic blood flow in ductus venosus, a lot of diastolic blood. Very good. And this is very bad. So a Doppler report comes to you very complicated, like all these values, PSV, RSV, PV, AV, all that. And the obstetricians who have not studied Doppler will get very confused. They get a lot of pictures also, a lot of lovely looking pictures. And we've seen that most of them will ring up the one who has done the scan. Please tell me whether to do cesarean or not. Now that decision is yours. That is a clinical decision. That doesn't go by what the radiologist or the imaging specialist. So you learn how to look at the waves at least, if not the values. Umbilical after second trimester will show diastolic blood flow. If it does not show diastolic blood flow, reduced, absent, reversed, very bad sign. Very simple. But there are charts, there are values. Look at the charts if you want to look at the values. They're available on Google or they are available in all the books. So when you look at the umbilical vessel, the systolic and diastolic, the diastolic flow is 50% of the systolic. So umbilical way are always dilated. Why? Because umbilical way arteries are bringing impure blood out. Two umbilical arteries always dilated, should not be in muscular artery, but in fetal umbilical artery it has to be dilated. Impure blood is coming out to the placenta. So this is reduced, this is absent, this is reversed. Very easy to say. And this, you will do some treatment. This, if it is, that means 70% of placenta is gone. So you are going to try to deliver. If it is this, then even if you deliver, the baby is going to have some morbidity. So deliver at the right time. So don't let the blood flow reverse and catch it early. So when umbilical Doppler are altered, then we do all the multi Dopplers. And see here we're doing the uterine and the cerebral. So cerebral is very important, very easy to pick up the circle of Willis. Anybody can do it. And you can see it very easily. And you can put the cursor in the middle cerebral and you get the cerebral veil pattern. So it is a muscular artery. The diastolic flow should be 30% of the systole. If it is more, then the more blood is going to the brain. That means decompensation has started. Then the veins are because the umbilical vein is bringing pure blood to the fetus through the venous system, through the ductus venosus, inferior vena cava, and then to the right heart of the fetus, and then foramen ovale, left heart of the fetus. So the venous system, if it is not dilated, if it is constricted, pure blood is not coming. Hypoxia, hypoxemia, acidosis, all can be diagnosed. So ductus venosus tells you whether it is acidosis, and very easy to pick up ductus. It's a bright red here, whether longitudinal, and very easy to pick up in the first trimester also, where it will tell you the chromosomal anomalies also. So reduced, this is normal first trimester, second trimester, third trimester, it should be fully dilated because the baby needs a lot of oxygen from the fetus. So ductus venosus, if it is reduced or reversed, indicates urgent delivery. Umbilical vein patterns are usually monophasic. If they become bi or triphasic, sine wave, then again, it's a major problem, but we usually don't look at it. We also don't look at the IVC Dopplers, but these are one of the values. We look at the ductus venosus. This is how. Then we look at the uterine side, finally. So uterine, as I told you, 30% of blood flow in non-pregnant, the artery is small. And when placentation occurs, the artery becomes big. And you see the diastolic blood flow is 50%. So it will predict the pregnancy-induced hypertension. So when implantation is normal, the diastolic blood flow will be more. Diastolic notch will disappear. If the notch persists, diastolic blood flow does not increase, this mother will have pregnancy-induced hypertension and all the complications. So uterine artery Doppler at 13 weeks, at 20 weeks, at 26 weeks is a very important. How it deteriorates, umbilical artery gets affected, brain sparing occurs, and then all the other vessels get constricted, and then the venous. Based on all this, we have a staging system, a simple one. Stage 1, when your cerebral has become like, when your umbilical has become like cerebral and the cerebral has become like umbilical. Usually umbilical vessels are like this, 50%, but if the cerebral MCA becomes like this and the umbilical, so altered cerebral umbilical ratio, CPR. Stage 2, all have become abnormal. The cerebral, the umbilical, maybe end, absent or reversed, and even the ductus. Stage 3, all are very abnormal, all are showing reversed, including the MCA now, because of too much decompensation, it has also deteriorated. Then they are divided A and B. A is when the amniotic fluid is less than 5. So as it is, if the amniotic fluid is less than 5, it's an indication for delivery or more. So the rationale is that if it is a stage 1 fetus, it's mild growth retardation. You can do as outpatient. If it is stage 2 and 3, you need to admit and do conservative management by whatever method you believe in. And most of the stage 2 will be observation. Stage 3, you have to decide the maturity. And if you have time, give steroids and Maxelf and deliver them. So this will simple staging system selects your patient when to deliver. And it is a very simple 4 fetal vessel, 1 cardiac has to be evaluated. So this staging is very, very simple and can be applied by all the obstetricians. Let's see how it goes. Growth lags, cerebral blood flow increases, more redistribution occurs, weight reduces, absent end diastolic blood flow in umbilical, then ductus venosus, then finally biophysical profile, and then finally abnormal CTG. So if we go only an abnormal CTG and not Doppler, we are going missing 21 days to this, and fetal death may occur. Plus, it does not give you a chance to do anything conservative here. Otherwise, if you pick these up, color Doppler, you can do conservative treatment at 32 weeks or 33 weeks. How do we monitor? We monitor if your measurements have to be taken 2 weeks, Doppler 2 weeks. If it is abnormal and admitted, maybe bi-weekly or maybe every 2 days. Our aim of delivery is that we want a live fetus who will survive. And when to deliver, the risk of prematurity versus a hostile intrauterine. So you see what is the risk of prematurity, what is the NICU facility, what is the degree of hypoxia, acidemia, hepatic metabolism by looking at ductus venosus. If it is all there, don't deliver in small nursing homes, shift to tertiary care. And shifting intrauterine is much better than delivering and shifting the baby. And this is the guideline which we made. Fortunately, I was one of the part of the Berlin consensus, and the 3 of us discussed in 2015 the first guidelines, and we said that there has to be GROW, that is gestation related optimal weight. And then we said that at what age you should do what. So 24 weeks, discuss with parents, this baby you're going to lose or have severe handicaps by like blindness and all. So no sense in giving a cesarean section to a 500 or 600 grams a baby. And otherwise, if the survivability is there, then after 28 weeks, we'll try to deliver. But because remember, there is a road to death. So if acidemia is occurring, those babies are going to die. So you have to deliver before acidemia or just as acidemia has occurred. And then it is this. Can you have the first one before I do the other? I will finish this in 15 minutes. So here, sorry, I was at 5 o'clock to go in another webinar, which I'll go later. So this is the RCOG guidelines, and this everyone can download from the internet and follow that. 37 weeks, 34 to 37 weeks, and 32 weeks. And the plan, which babies will be alive, which babies will not be alive. So intervention, if it was picked up early, aspirin and dietary supplements, stop smoking, improve the environment. So when Doppler is normal, growth retardation is doubtful. It may be constitutionally normal baby. Small fetuses with normal Doppler left alone. Fetal nutrition scoring can be done. This is the latest which has come. It is still not applied in clinical, but with 3-dimensional ultrasound 3D, we can do this. We put this all into a step-by-step series books, which if you are not good in English, you can read them in Spanish and Chinese also. And we have, of course, the FOGSI textbook on ultrasound and all the books where you can go through. Last slide. Causes of FGR may be environmental, chromosomal, single gene complex. If we do combined test, we pick up only 75%. If we do amniocentesis, we pick up all the chromosomal defects and single gene. But if you do a good ultrasound, you can tell what the cause is. So clinical information by ultrasound is much, much more than molecular. Thank you very much for inviting me here and sharing my views on fetal growth restriction. Thank you very much.
Sir, it was an excellent delivery, sir. Even people who are not doing routinely ultrasonography have learned a lot, and you are really guru of gurus. And as you have mentioned, sir, that we are still student for certain things, but I feel in many things you are guru for all of us. And you have explained so well, because this is the topic of growth retardation is very confusing to many obstetricians also, especially when you are into sonography, you are into it, fetal medicine, you understand better. But as you have mentioned that this is growth retardation affects the 10% of the fetus in Western world and about 23% in low and middle income group countries. And we know that this is the second most common cause of the perinatal mortality after prematurity, and stillbirth occurs in 30% of these growth retarded baby. So you have explained we are into maternal health. At the same time, we have to also have to be in our perinatal health. You have explained very well what are the causes of this growth retardation. You mentioned about the genetic potential, and you also mentioned about the substrate supply. And these are very important things that the nutrition, which has under control of us, under control of pregnant women, nutrition, drug abuse, etc., can be avoided to prevent this growth retardation. But genetic, we really can not avoid, so this can be explained. And as far as the fetal causes are concerned, that poor placentation, that is aneuploid and infection. And we have said in torch infection, malaria in our country, tuberculosis and syphilis are very important, that it can cause fetal infection and cause growth retardation. And placenta also, you explained it very well, that it can be due to hypoxia because of the PIH or some other reason, filamentous attachment or any other cause. And therefore, sir, you explained so well that I'm really impressed, and all the other, delegates or whoever has joined are also impressed. The sonography, why you mentioned, is the first, stage, first trimester. The dating is important. You explain about it 7 to 10 weeks, explain about 10 to 14 weeks, and later on how the growth is very important. And when you detect, there are some babies who are constitutionally small but normal. But some babies, 30 to 40% of the babies are fetal growth restricted. And those babies, we have to take care. We have to find out what are the causes. If we can correct it, we should correct it. And otherwise, we have to deliver them in time. So nowadays, as you mentioned, that in the past, we used to do pubic symphysis and a fundal height parameters with the abdominal circumferences of the mother. But now the sonography has become a part of the obstetrician. They have to know each and everything and how it helps to differentiate growth retarded fetus, small for gestational age fetus. And sir, it was an excellent delivery and treatment part, as you mentioned, radiologists will not say whether we should do cesarean section, when to do, or whether we should do induction or labor. That depends upon the clinician. The sonologist or the radiologist will tell you how much is the growth retarded. Mild, we can leave it alone. We can do on the treatment monitoring every 2 weekly on the OPD basis. Moderate, we can do hospitalize and decide, after monitoring, decide termination. And grade 3 should be, immediately delivered. And as you rightly said, that when the Dopplers becomes reversible, we should not wait for that. Otherwise, there will be lots of problem for the baby, neurological development, etc. will come. So we have to take a right decision at the right time to terminate this pregnancy. Thank you very much, Lakshmi, Sarita, Sir, and Ashok Kumar, Rishikesh Pai, for giving me this opportunity. Over to you, Dr. Charmila.
Thank you so much. It's an honor to be in a program where my guru is there as the other expert. Thank you so much for the opportunity, Dr. Sarita. Narendra sir, it was like so mesmerizing. It was actually, it was so simple, but it so elaborate. Each point was brought out so clearly. I think there's a remark in the chat also that there's a person, Dr. Asmi Fatima, who said, I'm a recent promotee to MBBS final year, but I could grasp quite a lot of concepts and all owing to this phenomenal teaching. And I think I should reiterate that, because for every clinician as well as for a person who has joined MBBS, it was equally clear. And we have listened to your talk so many times in the past, so many years, but still it's always new and everything is so fresh. Actually, I wanted to ask you, like, your journey in fetal medicine, we know, but you're always for the girl child. That we have seen for almost 20-25 years now. Like, how did your passion for saving the girl child start, sir? Because you have actually sponsored the yatra which we did from Kanyakumari to Agra during ICOG Agra, and we could bring 45 young girls who have never traveled by train, have never left their town, and you made it possible for them to reach Agra. And all of them are really empowered now, and most of them have gone into big colleges and have gone into jobs also. What is that passion which made you start this journey?
So it's a long story. My Hindi biography tells it, but the English one you will get by December. That will also tell you. Now, what happened was, when we were in our house job in Aligarh Medical College, then our boss, Professor Kusum Saxena, called us and said, what thesis both of you want to do? Because same department, same batch, 4 PGs. So we said, see, ultrasound is coming, so let us do ultrasound and one on CTG. So we were both allowed 6 weeks leave after finishing a year of house job to go to Bombay, KM, and that's how I'm very close to everyone in KM, to learn. And Professor M.Y. Rawal and Dr. Kelkar taught us ultrasound. So that is a love for ultrasound started. And we were the first 6 papers in India on congenital anomalies in FOGSI journal are by us, and a lot of first on that. So that is a long story. Now then, anything new used to come, both of us were very curious, and we would do all that. So when laparoscopy came, we went for laparoscopy, and we were the first in here. And then when Jaideep said, I want to go to laparoscopy to Germany, we had money only for one person to go. So she went. And from there, she gave me a fax that, can I stay back for 15 days to learn IVF also? So that is how we shifted into IVF. So it slowly went on. Then finally, when 2008 came and I got elected as president, So the dilemma was the president's theme. And I talked to Dr. Kamini Rao, who was my probably the best friend, the youngest president ever she was. And I was probably the second youngest. So I said, what should I do, Dr. Kamini, in my year? So you are master in ultrasound, you gave ultrasound theme. I said, no, but India still is struggling. India still has no women empowerment. And that is when it came to my mind that we should work for women empowerment. So 2008, we said we will do something where the call would be Chalo Gaon Chale and Beti Bachao Beti Padhao. That just came one day in my mind. And that is how the Beti Bachao Beti Padhao, thanks to Prime Minister Narendra Modi, who took this slogan. He doesn't acknowledge us, but it's okay. So, and then it's no end. And it's still going on through our NGO. Now Niharika is doing much more work on Beti Bachao, Beti Padhao. Now it is Beti Bachao, Beti Pad Gayi. Everywhere the girls are now educated. So, but it is the boys who have not understood. So Beti Bachao, Beta Samjhao is the new slogan.
Sir, I remember that in 2008, when you took over as a president, that time also you had done a rally for the Beti Bachao, Beti Padhao. I remember that, and it was very, very successful at that time. So thank you very much, sir. And secondly, sir, you were the one of the person for the growth chart, that you have mentioned about, in the Germany, you had made a guidelines. And of course, we have a FOGSI book also on the ultrasound, which is excellent. And we all are going through that book. So it is really, really good for all our members to learn and implement in their practice, sir.
Dr. Madhuri, the new edition of FOGSI ultrasound book has to come. FOGSI office has to clear it with JP. JP is telling me you are the editor, please write it. So Madhuri, you clear it so I can start writing and bring it in.
Sure, sir, sure, definitely, sir, definitely. You give me one email, I will definitely.
I will, thank you. Charmila, you are the co-editor now.
And another aspect of your journey which is so fascinating is you allowed your partner to grow equally, and you've got two lovely children who have been brought up so well, and they are actually like it's quite inspirational the way the family is gels together, and that's quite inspirational, sir, because madam is also a great academician, and she has grown equally well. That doesn't happen in so many families in India, and that's very inspirational from your side.
So that's where we took turns. She took the back seat initially because the initial part of the children. And then I took a little bit back seat when she was coming up. So it is mutual. And it is, you cannot grow. You have to let the other person grow. So my mantra is that if you want to be happy, you have to make the other person happy. You can't be happy if the others are not happy.
But sir, you started women empowerment from your own home. I mean, that is the most powerful message. You gave it to everyone. And I remember I was HIV committee chairperson when you were FOGSI president. So I still remember that. I know you are an academician par excellence, but you are a great human being. How much you encouraged me as a HIV AIDS committee chairperson. You helped me starting that Asia's first HIV PEP helpline. We could do under your presidency that World Congress on HIV in Women. So I have very fond memories of you as a great president, great human being who promotes and encourages the newcomers and those who are in the team. So thank you for that also, apart from your ultrasound as a great achievement you have achieved in this field.
Thank you. Thank you, Dr. Lakshmi.
Actually, I would say the words of Guru Nanak here, like no man can in this world live in delusion. Without a guru, none can cross over to the other shore. And I think you've been inspirational for so many people in FOGSI, elsewhere also, that they hold your hand and come to shore and probably go much better. Thank you so much for those that wonderful talk, sir. My Guruji, Dr. Madhuri Patel, is also there, because that's why I thanked everybody, because it's an honor for me that I'm there with Madam. Madam, would you like to say something before we close the program?
Is there any question in the chat box?
There are no questions, but I actually had one for sir. Can I ask that, sir?
Yes, yes. That is always ready.
Yes,
Actually, in 10 minutes, I have to speak on
That's what I'm
probiotics in other webinar.
So only
Oh, we'll
There's
name
also
you,
ICOG's
we'll name you
webinar.
soon. We'll name you soon.
EMOG's webinar, yeah.
only one
Quick
question.
question, yes,
Yeah,
very
yeah.
quick.
So in late FGR, we always have a confusion. In late FGR, we always have a confusion. In early FGR, when you have a person with hypertension, who's got some other metabolic problem, you are ready for that early FGR. But in late FGR, when you do advise an ultrasound to pick that that baby which can go for a stillbirth if not monitored?
So for me, 5 ultrasounds in pregnancy should be there. The first is a dating scan. First actually is a confirmation of pregnancy with dating. And that makes your date at 7 weeks, 7 to 10 weeks. The second most important scan for me is 11 to 13 weeks, 6 days, which will put out the chromosomal marker. The third scan is the 20-week fetal anomaly scan, which is again very important. And then I would do one at 26 or 20, between 26 or 28 with a color Doppler. That is where my first signal that something is wrong with this baby. And if something is wrong, then I'll do an ultrasound every 2 weeks for the rest of the pregnancy. So the 5 scans, and then you do as many as you want, because then you want to deliver. So look at the liker, look at the environment. That's it.
Thank you so much. Sheila, madam.
Yeah, thank you, Dr. Narendra. As always, it was pleasure listening to you, and excellent deliberation, as well as the explanation was so well done, that anybody can understand, and how you explained the growth charts, because still many people are not aware of it, and if we look at the growth chart itself, I think we can make out, and you told the differences between FGA, then the SGA, and I mean, not unnecessarily, there is no need to panic is the best part, because we have a small baby. That does not mean that we have to always take it as, and the ultrasound percentage, the error percentage, and everything what you shared. So thank you once again for participating in this and giving us the excellent information. Thank you.
If you want to listen to me talking on probiotics, join the other webinar.
Thank you, Lakshmi, Sheila, Charmila. Thank you, sir.
Thank you, ma'am.
Thank you, Sunala, sir, and everybody. Sarita, thank you very much.
Thank you, Madhuri.
Thank you. Bye-bye.
Dear
Thank you,
delegates, Mitali, you can stop the recording and you can end the meeting. So
Yes,
thank you so much. Tata, bye, good night.
Thank you, ma'am. Thank you.